Hi, and welcome to a new episode of Dysphagia Matters. We are Jule and Julia, and our guest on today's show is Dr. Pamela Dodrill. Pamela is a pediatric speech and language therapist. She trained in Australia and has worked in Boston in the USA for the last 10 years in the Neonatal Intensive Care Unit, short NICU, at Brigham and Women's Hospital. Together with her co-authors, Pamela developed a consensus definition and conceptual framework for pediatric feeding disorders, and she was part of the FOIS-P team, so the Functional Oral Intake Scale for Pediatrics. We talk about these two projects and her work in the NICU and how it differs from other settings. Pamela also talks about the feeding and swallowing assessment pathway in the NICU and how the treatment is guided by a thorough assessment. We conclude the episode by asking Pamela about her vision in this field and what research we need in the future for this population. Enjoy listening.
I think the field of pediatric dysphagia is a bit of a niche within the niche of swallowing disorders, and many clinicians are aware that it exists, but that's about it. So we're happy to have you on this episode today.
Thank you. I'm delighted to be here.
So how did you come to work with children with dysphagia, since it's not a very typical area to work in?
I guess the long story is I knew I wanted to work in health, and then I decided to go into the field of speech pathology. I was always interested, I thought, from an early stage in the medical aspects of our work in speech pathology. I was fortunate enough to train in Brisbane in Queensland in Australia at the University of Queensland, where there's a lot of fantastic clinicians and researchers. I was very fortunate that the lecturer at the time for the dysphagia course was Professor Liz Ward, who has contributed significantly to the field of adult dysphagia. I mean, she's published many textbooks and hundreds of manuscripts in this area. So she was a real inspiration to me, and I think really honed my interest within our field into the aspect of dysphagia. And then for a little while, I worked with adults. I had a fantastic job at the Royal Brisbane Hospital working with adults, but then quickly transitioned over to working with children at the Royal Children's Hospital, which was just next door. And that's where I worked for the next 13 years. And I did my PhD while I was there. And that's where I really found a love for this area. And then more recently, I've moved to Boston in America and have worked at the Boston Children's Hospital and then the Brigham and Women's Hospital NICU, which is again next door. It's been a bit of a pathway, but I think fairly early on, I knew I wanted to be involved in the medical aspect of our field. And then I just saw inspirational clinicians and researchers in the dysphagia field. And that really then took my heart in this area. And then certainly the patients, what keeps me working in this area. I really love working with this population.
You were part of a team that developed a conceptual framework and a consensus definition of pediatric feeding disorders. The paper was published in 2019. What were its findings or conclusions?
Yeah, so this was a really important project that I think we had to work on because historically pediatric feeding disorders lacked a universal or universally accepted definition and diagnostic code. Different professions were trying to describe the same things but using different words, and it caused a lot of problems for the patient group. So it was hard for families to get accurate diagnosis and recognition of their symptoms. Sometimes it was hard for them to get access to the care they needed. Sometimes, like I say, there was just difficulty communicating between different professions, and even hard to find literature to guide your practice when different people were using different words. So we really recognized that we needed to agree on a unifying diagnostic term and then obviously work towards getting an ICD diagnostic code to go with it. So for those who aren't aware, per this multidisciplinary consensus definition, pediatric feeding disorder is defined as impaired oral intake that is not age appropriate and is associated with medical, nutritional, feeding skill, and or psychosocial dysfunction. So this consensus definition was really grounded in the World Health Organization ICF model, so the International Classification of Functioning, which classifies the impact of disease in terms of what they used to say impairment, disability, and handicap, but it's been reframed more recently into impairment, activity, and function. So at the gist of all of this, we wanted to recognize that for feeding skills to be fully functional, they need to be safe, efficient, and age appropriate. And that dysfunction in any of these areas constitutes PFD. So needing special feeding equipment, positioning, strategies, modified food or fluids, or relying on nutritional supplementation. So whether that's given orally or via like a gavage tube. So what we really wanted to recognize, and we had parent groups working with us on this project, and we were really trying to be a voice for their cause and recognize that children with PFD have extra needs compared to other children. They're the kind of kid that you just can't leave them with a grandparent or in a daycare facility without special food or fluid, special feeding equipment, or a long list of special feeding instructions. And the idea was absolutely not to stigmatize these children or their families, but it was to recognize that these children need extra support needs. Back in the day, if any kind of feeding outcome was reported in the literature, it was often just did the child end up with a G tube, a gastrostomy tube, or did they end up with aspiration pneumonia? But there's a whole spectrum of children who have feeding difficulties that result in them needing special food or fluid equipment, and that wasn't always being recognized. And so that's really where this came from. And like I say, also using common terminology across different professions. So anyhow, we have been able to get that consensus definition out. It has helped us to advocate for a new ICD code, new diagnostic code, but there is still ongoing awareness work that needs to happen. And we've been partnering with a group called Feeding Matters. They are based in the US, but they do work with families from abroad as well. And their website has a lot of information about pediatric feeding disorder and how families can use this term to help advocate for improved access to services for their children.
That's really interesting, and it's also a very important project because in German we also have a problem about the terminology, and there's so many different words and everyone is speaking about something different.
And sometimes we don't realize that the words we're using to describe it are old-fashioned terminology, and that when you actually talk with parents, some of those words like failure to thrive actually feel quite, sometimes parents take them as having a different meaning than what we intend them to. And it can actually make parents feel like they're somehow responsible for the child's feeding difficulties. And that's really not what we want to do. We want to make sure that we're recognizing that the child has problems in this area, advocating for services in this area, but using terminology that's modern and specific and appropriate to the condition, so that when we're talking with other professionals and certainly with parents, that we're being precise rather than using antiquated terminology that may not be useful.
Yeah, it has such a big influence in the work. Yeah. The children that are included in the definition of having a pediatric feeding disorder, do you differentiate between the etiology, whether it's like purely functional, or are there also children who don't eat because of traumatic experiences, for example?
Yeah, so in the main definition, we try to recognize that it can be multifactorial, and it almost always is multifactorial. And that's why we recognize that it's often associated with medical, nutritional, feeding skill, and or psychosocial dysfunction. And so that sometimes this starts off as a straight dysphagia, a swallowing disorder that then progresses into PFD. But then sometimes the pediatric feeding disorder persists beyond the original resolution of the dysphagia, that a child who early on has difficulty swallowing or is aspirating may go on to develop pediatric feeding disorder. But sometimes even as their swallowing matures, they no longer have dysphagia. They may still have an aversion towards certain foods, or they may still continue to require assistance that persist beyond. So it's not mutually exclusive having this diagnosis, but it's recognizing that it goes beyond other conditions, such as often the initial presenting condition, which may be dysphagia or a medical condition or a nutritional issue.
Great, thank you. So as you've already outlined, you've been working in the neonatal intensive care unit, short NICU, since 2015. What kind of children are you working with?
So I have been in my current job, which is just in the NICU, since 2015 at Brigham and Women's Hospital NICU in Boston. Before that, when I worked in children's hospitals at Boston Children's Hospital and Royal Children's Hospital, we provided a drop-in service to the NICU next door to us. And so I actually think our service has evolved because we now have a full-time presence in the NICU, and that kind of changes who we are working with. So now that we're there all the time, we needed kind of a guideline to talk about who are our higher risk and lower risk, or bigger priorities and lesser priority patients, to help guide our practice. And we actually have a document that is available on our hospital website. We'll also provide the link with this podcast if anyone's interested, that goes through which babies we see. But essentially we have this high risk, low risk protocol. And so our SLP, we call ourselves feeding therapists in the NICU, just because it helps parents of newborns to understand what we do more, because obviously we're working on feeding more than on speech and language. Our feeding team automatically sees high-risk babies, which in this population we define as babies who have significant chronic lung disease, so bronchopulmonary dysplasia, those with significant congenital heart defects, significant neurological issues, so we're talking about grades 3 or 4 interventricular hemorrhage, babies who have hypoxic ischemic encephalopathy or any seizures, Some genetic conditions that we know are very high risk of silent aspiration, like Down syndrome and Prader-Willi syndrome. And then certainly any babies who have airway malformations, so babies with laryngomalacia, laryngeal cleft, those kind of conditions. So we automatically will see all of those babies, but we will see any other babies in our NICU as needed. In the other situations, the nurses will start to feed the baby. And if there's any concerns, if they're not progressing the way we'd expect, we would get involved with those babies. That was a little bit different than historically in the drop-in model, where essentially you just took the referrals and you'd go and see someone. And we often felt that we received the referrals a little bit too late and maybe just on the most complicated babies. And we felt like we could actually provide services to more children. And we've been able to do that now that we have an increased presence and that we're actually based in the NICU.
That's really good. Yeah. And from your experiences, so why are these children in need of SLP or feeding of the feeding team? Especially, what is the difference oftentimes between the babies at high risk or at lower risk?
Yeah, so the biggest issue we see in this population is poor suck, swallow, breath coordination. So when you walk around general level 3 NICU, most of the babies can suck on a pacifier just fine, but they have difficulty once we introduce liquid flow, so from the breast or the bottle. And obviously our profession is trained in the anatomy and neurology and physiology of swallowing and breathing. And so I help able to guide management in this area. Everyone in our team, actually, all of our SLP feeding therapists in the NICU previously worked in a children's hospital. And I guess more than anything, we're trying to set these infants up with a safe feeding plan from the beginning so that hopefully most of them don't end up needing continued feeding therapy later on. Although obviously there's always a small proportion of these infants who do continue to require support services afterwards. And part of our work is advocacy, and we're making sure that we do link those children in with ongoing outpatient support for later on. But as much as possible, we're trying to avoid problems that you see later on if early problems have been missed. So like I say, the biggest issue we see is poor suck, swallow, breath coordination.
And what about premature babies? Can they be in both groups or not necessarily in any of those groups? And maybe just for our listeners, could you give a brief definition of what prematurity actually is?
Yes, do you know, I missed that one. That was the big one. By definition, so your due date is at 40 weeks post-menstrual age. So that's full term. Below 37 weeks, corrected gestational age is considered preterm. And then we obviously see degrees of prematurity. So the youngest babies are born less than 28 weeks gestational age. Then there's those born less than 32 and up to 37 weeks. We actually categorize anyone born less than 30 weeks gestational age as being high risk, particularly high risk, because they tend to have very immature lungs, which means they have very immature breathing. So then they continue to have the effects of that even as they getting close to the equivalent of term age or their due date. And so certainly any babies less than 30 weeks also fall into our high risk group, though those babies also tend to get caught by the other criteria as well, because they do tend to be the ones who end up with prolonged chronic lung disease. So bronchopulmonary dysplasia, many of them do in fact have congenital heart defects. That's how they kind of fall into that category, but we will automatically see anyone who's born less than 30 weeks. But we do end up picking up some of the older preterm babies as well, if they don't follow the standard path that we'd expect.
And what would you say are the main differences between working as a dysphagia clinician on the NICU compared to other settings, despite that probably everything is kind of smaller?
Yeah, yes, smaller is definitely number one, but there are a few other things. First of all, I think the thing that's different in the NICU is that most of these babies start off with feeding difficulties, whereas obviously in a healthy, well newborn unit, most babies can feed fine and can eat enough. So in our setting, in the level 3 NICU environment, about 95% of these babies start off with gavage tube feeds and then progress to oral feeds. So that's a little bit different in that almost everybody starts off not being able to feed well, and then we hope that they will advance towards feeding well, and we pay particular attention to the ones who don't follow the standard path. I guess one of the other differences in general about infants versus older children is just the way that they drink. So you and I, older children, adults, take sips of drinks and bites of food, whereas babies have a breast or a bottle in their mouth for 15, 20, 25 minutes at a time, and there's liquid flow throughout that time. You and I, we know from literature, take about 10 to 15 mLs per swallow, whereas babies take about 0.1 to 0.2 mLs per swallow, but they need to drink actually a lot of liquid relative to their body size. because they're growing so much, and in particular their brain is growing, which is very metabolically demanding, so they need to drink a lot of liquid. If you even think about it, so if in a minute a baby takes swallow every 1 or 2 seconds, say it's every 2 seconds, and they do 30 swallows per minute, and they, even if they feed for 15 minutes, which is kind of on the earlier side for a baby, many take 20 or 25 minutes, but say 30 swallows per minute, and then 15 minutes of feeding, that's already, we're up at 450 swallows just to finish one feed, which is what they do every 3 hours, so 8 times a day. So during that feed, they have to keep going between swallowing and breathing, swallowing and breathing, swallowing and breathing the whole time. Even if you or I are chugging a drink, that's an American term I've learned, when you're drinking very fast, we might take 5 or 6 or 7 swallows in a row. We don't take 450 swallows in a row. And so even if you're breathing a tiny bit fast, and the hallmark of prematurity is immature lungs, and so they all tend to breathe a little bit fast and a little bit harder, it can be hard to switch between swallowing and breathing. So that's a difficult thing that's different in babies as well. Probably another thing related to that point is just the fact that babies feed every 3 hours, 24 hours a day. So usually at least about 8 times a day. As therapists working in the NICU, we don't work 24 hours a day. In our setting, we do 4 10-hour days to try and cover more of the feed times. But even still, we don't have nighttime coverage. And at the moment, we don't have weekend coverage. So that means that even though we are the feeding specialists in the NICU, we can't be there for every feed. So we have to make sure that we can't just feed the babies. We also have to be able to train anybody else who's feeding the babies, which is often nurses and certainly their parents, in using any strategies that we think would help. And I guess probably the other quick things I can think of that are just different is just how at the end of their NICU stay, feeding is the last kind of task that you're working on, and it can impact on length of stay. So there's a little bit of pressure for us to make sure that what we're doing is being helpful. But equally, feeding problems are one of the major reasons for babies to get readmitted post-discharge from the NICU. So we want to make sure that we get feeding right so that babies can go home to their families as soon as possible. But we also don't want to make sure that it's rushed, because we don't want them to have problems that cause them to be readmitted later on. And I guess probably the last point then that I just is occurring to me that's different in this population is just the very high rate of silent aspiration. So if you or I swallow a drink and it goes the wrong way, hopefully we will cough and clear it out or make some kind of effort. In this population, that's really not the case. We have done some work and we've published some literature combined with our colleagues next door at Boston Children's Hospital, where we looked at a couple of years worth of video fluoroscopies. And in babies less than 6 months of age, even in the ones we know are aspirating because we can see it on imaging, only about 5% of them actually cough. So 95% of them don't, or 19 times out of 20, we do not see a cough. Often we're looking for more subtle signs that make us concerned. So it's things like failure to wean from respiratory support, so the baby who continues to require supplemental oxygen longer than we would expect them to, or the baby who continues to have adverse events, so things like oxygen desaturation events, bradycardic events during feeds, or just even increased work of breathing, so tachypnea or increased effort for breathing during or after feeds. So those are the things that we're often looking for. That's a little bit different than how we see dysphagia and aspiration present in older children and in adults. It's a more subtle pattern, and it certainly is easier to pick up if you're working with these babies daily, that you see that they're just not following the pathway that you'd expect, and might be a little bit harder for you to pick up if you're just doing like a drop-in assessment every so often. So those kind of things are a little bit different in this population than what you would see in other populations.
You've already talked a bit about the diagnostics. What does the process look like? Does it follow the same structure, like screening, clinical bedside evaluation, and then instrumental assessment, or is that different?
Yeah, and look, I'd say, again, this is different to what we do now, that we have a full-time presence in the NICU versus when we used to do a drop-in assessment. When we did a drop-in assessment, it was very much like you'd see in other populations, where you would do a standardized assessment and then make some guidelines and then watch how the child progressed and see if imaging would help. At this point now that we're involved in the NICU, we are actually tracking these babies and their medical health conditions from well before they're stable enough and old enough to be able to eat by mouth. And we've generally already spoken with their parents about the feeding plan that we tend to follow before they've even started feeding by mouth. So with our high risk, low risk protocol that we have for the babies who are born less than 30 weeks gestational age, or who have any of those other high risk criteria that we mentioned, chronic lung disease, congenital heart defects, structural changes in their larynx, we've already spoken to their parents that when they start feeding by mouth, we're going to start with all the compensations in place, the slowest flowing liquid flow. We're going to make positional changes, we're going to use strategies. Whereas for the other children in the lower risk group, we'll explain to them, we're going to start off the way we'd start off with a full-term baby, but if there's any concerns, we do have things up our sleeves that we can use to help you. So that kind of changes our diagnostic process a little bit, because we've been able to show from the literature, from our experience, from collecting data in our own population, that this higher risk group, we don't need to start them off like a full-term baby and let them fail with that plan before we can advocate for them to have special compensations put in place. We start them off with all of those strategies in place and then liberalize a plan later on more if possible. So that has changed our diagnostic process. But like in older children or in adults, we try things that we know from the literature and our experience make a difference. But if we're still finding that the baby is not managing the way we would expect, then we will go to imaging to help guide our plan if we just can't get enough information from what we're seeing at the bedside. And in this situation, all of our babies are attached to telemetry. So we are seeing oxygen saturation, heart rate, respiratory rate. But if the things we're trying still aren't producing the desired outcome and we're concerned we're missing something, we will certainly go to imaging the way we would in other populations.
What kinds of imaging are there for this population?
Yeah, so like in older children and adults, the two main imaging that we would use are video fluoroscopic swallow study, or FEAST, so fiber optic endoscopic evaluation of swallowing. I have to say, in our hospital, we do have access to fluoro, so video fluoroscopy, on weekdays. So we have a spot each day, Monday through Friday. And so that is our main source of imaging. I'm very aware that there are some people, particularly in some NICUs, that are based in a maternity hospital, in an adult hospital setting, so they're not in a children's hospital, who may not be able to access fluoro on site. And in that case, they may have to put the baby into an ambulance to transport them to a children's hospital to perform imaging. And in that case, I have to say, if we did not have access to fluoroscopy on site and we were not able to make that happen, we would definitely use FEAST versus not doing any imaging. Certainly when I've worked with older children, and I know people who work in adults, FEAST is used a lot. The difficulty just in infants, obviously, as we talked about before, is just that they do so many swallows per feed that they will tend to do 30 to 60 swallows per minute, which means, as you know, that there's a lot of epiglottic deflection. So it means there's a lot of whiteout time in the swallow. Also because they're swallowing such small boluses, like we were saying, 0.1 to 0.2 mLs versus like the kind of 10 to 15 mLs that you'd see in an adult. It's just much harder to pick up liquid entering into the airway when you're doing small, frequent swallows. There's just a lot of whiteout time, and it's hard even when you do get opportunity to view into the larynx to see the liquid, because it is such a small bolus. So, I mean, certainly people do it, and people who do it a lot obviously use recording systems and playback and do get useful information from it. We feel we get more information from fluoro, and we have the fortune of having access to that on every weekday. So none of our patients have to wait more than 1 or 2 days to be able to get imaging if we think that would be helpful. But we would use other strategies if we didn't have access to that.
Oh, that's great. Last year at the conference of the European Society for Swallowing Disorders, you presented a poster entitled "Swallow Imaging Can Help Facilitate Safe Discharge Home from the Neonatal ICU and Reduce Length of Hospital Stay." What did you find in your research?
So what we realized is that there are some babies who just get stuck in their medical course in the NICU. So they have difficulty weaning off respiratory support. So they're still stuck on supplemental oxygen, so low flow nasal cannula, longer than what we'd expect, or they're taking longer to get to full oral, so full PO feeds compared to what we would expect. And we know that because with all of our babies, we track when we would expect them to come off supplemental oxygen and when we would expect them to get to certain milestones with their feeding. And when there are babies who are stuck, even if they're not coughing and choking, we look for more subtle signs, like we were saying before, oxygen desaturation events during feeds, bradycardic events during feeds, increased work of breathing during or after the feeds, or just really sometimes just failure to progress the way we would expect with coming off respiratory support or advancing the amount of what they need to take that they're taking by mouth. And so when we get to that point, we will often do imaging. So often these babies are getting close to their due date. the families are desperate to get them home, and we're looking to see what we can do to facilitate it. And when we did imaging in this population, we found that of this population who were stuck, and some of them were showing more clinical signs than others, more than 85% of them were in fact aspirating on the plan they were on. And when we changed the plan, in the vast majority of these babies, we were able to get them to full PO feeds safely within 1 to 2 weeks after the imaging study. So we had the information from the study, we made a change in their feed plan, and then they stopped having the adverse events. They got to full PO feeds and were able to go home. So what we were really arguing is that if a baby is stuck, it can be because they're silently aspirating, and getting that extra piece of information can help inform your plan. In this case, we don't empirically thicken liquids in this population just because of difficulties of adding thickening into their feeds. It's not to say we never do it, but often we'll try other things first. And when we've tried everything else and we see on swallow studies that they're aspirating on thin liquids and we change their plan, many of these babies go home. So we're trying to argue that when babies seem like they're stuck, it's something that you should consider as part of their management plan. And in our experience, it often does lead to a change in their feed plan, which then does get these babies home with a safe feed plan.
And is there also anything that clinicians need to consider when deciding to do swallow imaging?
I guess the first thing I would just say is that silent aspiration in this population is higher than in other populations. So be suspicious that aspiration may be happening if a baby is not advancing, even if they're not coughing and choking during feeds. So that's one thing, and that's where imaging can definitely help inform the picture. The other thing about imaging, I think, is it's only useful if you go in with a clear plan. And so you really need to know what information you're trying to get. And it's certainly helpful if the person who has been working with the baby clinically can also do the imaging, or can have a conversation with the person who's doing the imaging so that you have a clear plan about what you're trying to get out of that study. So, for example, if there was a mother who has worked very hard to establish her milk supply and is very interested in trying to breastfeed the baby at the breast and or use her breast milk, when you go into the swallow study, obviously, if you see that this baby is aspirating with a faster flow, you do things like going to a slower flow and or changing the position to try and maintain thin liquids in a safe way if possible. Whereas if there was another baby who was already on formula and who had signs of reflux as well as swallowing problems, and who there was a thought that thickening might help both with swallowing as well as with their reflux symptoms, in that child, if you see that they're aspirating, you might more quickly go to trialing thickened liquid versus going to a slower nipple and positioning changes. So the information you get out of the fluoro kind of also relates to what questions you asked during the fluoro and which conditions you trialed. We do have a protocol in our unit that by the time we're doing imaging on babies, most of them are close to going home. So most of them would need to eat somewhere in the range of 45 mLs to 60 mLs every feed. So for us to clear someone on a plan, we do want them to take at least around 30 mLs during the study to clear them on that plan. We don't want them to do 1 or 2 sips and assume it's fine if without looking further. Obviously, we don't keep the fluoro running during that time. We'll take samples at different periods during that time, but we want to make sure that the plan that we recommend is safe and hopefully will help the baby get to where they need to get with their feeding.
Yeah, thank you. That's really, really interesting. And you've already talked about the treatment plan. What are the treatment options for the children you work with who have feeding and or swallowing disorders?
Yeah, so I try to think about this in my mind, regardless of whether it's a baby or an older child or an adult. I think there's really 3 main lines of intervention that we use. We can either change the liquid itself, we can change how we deliver the liquid, or we can bypass our oropharyngeal mechanism and give the liquid directly into the gut. So that's some kind of tube feeds. If any of us as adults tomorrow had a head injury or a stroke and we ended up in the emergency room or ICU and we were alert, I think usually a therapist would be sent in to evaluate our swallowing to see if we could meet our hydration needs and swallow medication safely. And if someone was worried, I think one of the first line interventions people would use is to change the liquid, so to use thickened liquids. Thickening liquids is relatively cheap. It has an immediate effect. It often helps. The issue is, though, to thicken a liquid, you need to add some kind of thickening agent. And in the preterm population, sometimes we even worry about them being able to tolerate and digest formula well, which is why we work so hard for them to get breast milk wherever possible, because we know that they have immature guts separate to all of their other immature body systems. It's just not our frontline intervention in this population the way it often is in other populations, because we just worry about adding extra things into their food. It's not to say we never do it, but it's not our frontline intervention. So the main line of intervention that we tend to try is, rather than changing the liquid itself, is to change how we deliver the liquid. So we can do that by slowing the flow down with slower flowing bottle teats or nipples, knowing that slower flow makes it easier to switch between swallowing and breathing. If a mother is breastfeeding, we could have her pump until she's drained her breast of a lot of the milk, so then the baby will get a slower flow that way. But if they're using a bottle, we could use a slower flowing teat or nipple on the bottle. This is kind of the equivalent in an adult, that if rather than giving them an open cup, you would give them a straw to try and slow the flow down that way. Separate to the utensils we use, we could change their positioning. Most mothers, if you think about it, if you think of someone breastfeeding a baby, the baby's laying across the mother's chest, and there's almost a horizontal milk flow from her breast to the baby's mouth. But if you think about it, most people, if you hand them a baby in a bottle, the baby's kind of almost on their back in someone's arms, and the bottle is held above the baby. Just because the bottle is kind of awkward to hold, you tend to put the baby more on their back. And we know just with gravity, any liquid will flow more quickly in vertical, so downwards, than it would in horizontal on its side. For various reasons, mostly to do with the size of the bottle, we tend to feed babies in a version of supine on their back, where they're getting a vertical flow. And regardless of which bottle nipple we have on, it's going to flow more quickly than if we put them on their side. It's kind of hard. It's not intuitive to everyone to think about how to do a sideline positioning with a bottle, but you can put the baby down by your side like you're holding a rugby football, and feed the baby so that the baby is essentially on their side with one ear, shoulder, and hip facing up and the other one down. So then you can hold the bottle in a more horizontal position. So that can be helpful. The other benefit of being on your side is that one of your cheeks is on the bottom, which means if you need to stop and catch your breath, the milk will pool in that cheek on the bottom, rather than if you're on your back, where the liquid's going to pool in the back of your pharynx, where you kind of have to swallow it whether you're ready for it or not. The other advantage of being on your side is a strategy that we use called external pacing, where you would tip the bottle from a horizontal position down, so that you actually then drain all the milk out of the nipple, so that there's nothing for them to suck out of the bottle nipple or swallow. So it allows them, it kind of prompts them to catch their breath. That's easier to do when you start at a horizontal position and you're just tipping the bottle down a little bit to drain the milk out of the nipple, versus if you had the baby on their back, you'd have to like pull the nipple completely out of their mouth to have them stop sucking. So those three strategies, a slower flowing bottle nipple or draining some of the milk out of the breast, sideline positioning versus supine positioning, and then external pacing where the feeder is tipping the bottle down, those things can make a difference. If you think of external pacing like in an older child or adult, if you were to pinch the straw, you would be essentially external pacing for them. Whereas in a baby, what we do is we just tip the bottle down and drain the milk out of the nipple. That's how we can change how we deliver the liquids. Usually that's what we try first. As I was saying before, if those things don't work, we will sometimes consider changing the liquid itself, so thickening the liquid. There are special considerations. That's something we could talk more about, or certainly in our clinical practice guidelines that we'll have linked to this document and that are available on our hospital website. We go through when we would consider different types of thickening agents in this population. And then if none of those things work, we go to the third line of intervention, which is just bypassing the oropharyngeal mechanism and putting the liquid directly into the gut, which would be nasogastric or gastrostomy tube feeds. Like I say, it's kind of a variation of the same strategies that we use in older children and adults, just adapted to this population.
Thank you for that overview. Moving on to research. Pediatric dysphagia has increasingly become a focus of research. What is your vision for this clinical field, and where do you think more research is needed?
That's a big question. Obviously, all of our practice needs to be guided by evidence, and so data collection in general is important. I'd say particularly in this field because it's such a rapidly advancing field. A lot of the babies I spend most of my time working with on a daily basis just wouldn't have survived when I started working 20-something years ago, or certainly 30 or 40 years ago. Or if they had survived, they would have had very different outcomes than what they do now. A lot of premature babies who initially needed respiratory support just with medicine and the equipment that was available at the time, would start off on a ventilator and just get stuck on the ventilator. And many of these babies used to end up being tracheostomized, whereas now we see that most of these babies do advance off respiratory support. So less of them spend time on a ventilator. It's more use of non-invasive respiratory support like CPAP and high flow. And we do see more of these babies advancing to either low flow nasal cannula or just room air and discharging home that way. Also, because of other advances in the NICU, improvement in the delivery process and the medications that these babies receive, and in treatments such as therapeutic hypothermia, we just see less babies who are neurologically devastated compared to what we used to see. So this population is just not the same as when I started working, and it's certainly not the same as, around the time when I was born. And so I think it's really important that we just remember that this is a constantly changing population. I really feel strongly that feeding outcomes should be part of the core outcome set of any medical interventions in this population. So if the physicians are looking at an improved mode for weaning a baby off ventilation support early on, or some of the medications that they'll use to help babies with chronic lung disease, or even the outcomes of cardiac surgery, I feel like often we report on things like the child's overall neurological development. So they'll report things like the Bailey scale scores, or they'll report how many of these babies ended up with cerebral palsy or vision issues. I think we should argue that part of the outcome series that they report on in any of these interventions is feeding outcomes. And like I said, not just does a child end up with a gastrostomy tube or not, or do they end up with aspiration pneumonia or not? Are these children who continue to require special feeding equipment, special food or fluid consistencies? Because I feel like parents expect that their child is going to eat like everybody else their age. And it's really a very big functional limitation to children and their families if their child doesn't. And so I think it's an important outcome that we should be advocating to our physician group, should be thought of as part of the outcomes that we're considering when we're looking in this area. A couple of years ago, we worked with the authors Mike Crary and Giselle Carnaby, who developed the original FOICE, the Functional Oral Intake Scale for adults, and we developed a pediatric version, which we've been using. We've actually worked with them again now. We're putting out some more reliability and validity data and better instructions for the scoring this year. But essentially, for those who haven't looked at it, the pediatric version is a 6-point scale from 1 to 6, where 1 is nothing by mouth, all by tube. 6 is everything by mouth with no compensations required. And in between, you have scores of 2 and 3, where you're partially eating by mouth, but partially by tube. And then your 4 and 5, where you're eating completely by mouth, but you either need modified food or fluid textures and or special feeding equipment and strategies to help you feed safely. And it's just trying to recognize that these children have extra needs compared to other children. And it's like a score of their functional feeding outcomes. And so I think it's important that in the big picture, I think we're reporting on whether the things we're doing really are helping children to be able to eat independently, and or whether they need extra support needs.
You just had my heart jump when you said core outcome set. I can't thank you enough, like that you're advocating for people, researchers, just to really look at what is important to measure, as this is what I'm currently looking at in my PhD. And I think you've outlined it so beautifully, like why it is so important. So yeah, thank you so much. And I really do hope that in the future, researchers will take your advice into consideration, and this will be increasingly incorporated into core outcome sets or in studies looking at this population. So maybe to come to an end, do you have a brief take-home message for our listeners?
So I'm a clinician and I work with patients every day, and that's why I do what I do. I have had the benefit of being involved in research and continue to be involved in research, but I think in a scientific medical field like ours, we all need to be collecting data to inform our practice, whether or not you're actively going to write that data up for publication in peer-reviewed manuscripts, or whether or not you're going to keep it to inform your own practice in your facility. I think we need to be collecting data to inform our practice. So in this population, in the NICU population, even to start to collect data on when you would expect babies to come off respiratory support, when you'd expect them to start feeding by mouth in terms of their corrected gestational age, when you would expect them to get to full feeds by mouth, and then look at things like who are the babies who take the longest to get to full PO feeds, who's at the oldest corrected gestational age, and then look back at their data and see if there's anything you can think of that you could have done differently, starting earlier, using different strategies that could have helped inform the practice. Hopefully then we'll do better for these patients. And at very least, we'll be able to better inform parents what to expect in terms of how long their baby's likely to be in hospital and what support needs they'll need later on, and to help advocate to our colleagues that as well. Things like feeding difficulties in babies impact when the mother can go back to work. It can impact on whether she can send this child to a daycare facility. It can impact on how much time she needs to spend going to special support services. Modified food and fluids are necessary in some cases, but they are an extra expense and an extra burden on families. And if we can avoid them, great. But if we can't, we need to at least give people realistic expectations of what they need. There is a high rate of feeding difficulties in this population. Most of it is related to poor suck-swallow breath coordination. There are strategies we know that work from the literature and from our own experience, and certainly from imaging, where we can see that some things help more than others. And so we either need to be seeing how we can do things better, or at very least advocating that these are necessary treatments, and then giving people realistic expectations about the support needs of this population. I'd also say, for those of you who work in a NICU like I do, that's based in an inpatient setting in a maternity hospital and an adult hospital, you either need to have some plan to follow these babies up afterwards or to link them in with services. Many of the strategies that we do with these babies early on are really important at that time and help to get the baby home, but they may not be plans that the baby needs forevermore. And while we want to make sure that everything is safe, we also don't want to make sure that we're doing things that are over-restrictive for too long. And so we need to build networks, and so either follow these babies up ourselves or make sure that we're linking them in with someone else who can follow them up, so that they continue to have a safe plan, but that they also are able to enjoy development and move on from these plans when it's no longer needed as well. So I think collecting data is important. Making sure that we follow up, or that we arrange for these babies to follow it up, is important. And more than anything, I think talk with parents. I think they give us a lot of insight into what really makes a big difference in their situation or not. And I think certainly advocating for a core outcome series, the drive for that has come from parents to say, this is the information that we're looking for, is what to expect from our children and how we can plan ahead. And like I say, particularly for mothers, this really can have a very significant impact on their life, not just in the time their baby's in the NICU, but in the weeks and months and years afterwards. It can impact their return to work, how much time they have to spend on these activities, and how much less time they have to spend on all the other activities they do in the household and in the workforce. So I think as much as we can collect data, and then also look to the literature to make sure that we're doing everything that we can, that the evidence supports, to help support this population.
A big thanks to you, Pamela, for taking the time and sharing your valuable knowledge with us today. And to our listeners, thank you for tuning in. Remember, you can find all our episodes wherever you listen to podcasts and on our website, dysphagiamatters.org. Don't forget to follow us on Instagram @dysphagiamatters and on X @dysphagiapcast. Until next time, take care, everyone.